All right. Good morning, everyone. Thank you again for dialing into our Ask the Doc wellness presentation of women's health with Dr. Oko. All lines are muted until the question and answer portion of the presentation. Please also stay on in the end so we will announce our raffle winners. This month is Women's Health Month. Taking care of our health can sometimes take a back seat to all of the other responsibilities that we have to manage on our daily basis. If you have to take care of a child, an aging parent, or family member, you may find even less time for yourself. That is why we've teamed up with Dr. Oko today to talk about our women's health and hopefully become more knowledgeable on the important subjects so we can better take care of ourselves and advocate for our health. Dr. Oko's journey is a vibrant tapestry woven with dedication, empathy, and a commitment to women's health. Born and raised in Chicago to Ghanaian parents, her path began with a bachelor's degree in nursing, graduating with honors from the University of Illinois Chicago. She embarked on a 5 year career as a pediatric nurse, nurturing young patients and gaining invaluable experience that ultimately kindled her passion for a deeper specialization. She pursued her dream at Rush Medical College, where she obtained her medical degree in 2010 before embarking on a 4 year residency in OBGYN at the prestigious University of Chicago. Her rigorous training shaped her into a versatile and compassionate practitioner, earning her a respected place at Advocate Medical Group. Dr. Oko stands out with dual board certifications in obstetrics, gynecology, and obesity medicine, addressing women's health challenges like uterine fibroids, polycystic ovarian syndrome, and obesity with clinical finesse. Residing here in Elgin, Illinois, with her supportive husband and 3 lively children, Dr. Oko balances a demanding career with joy filled hobbies like cooking, gardening, and traveling. Dr. Ko is a trusted expert who embodies the fusion of cultural heritage, academic excellence, and personal passion. Thank you so much for being here with us today, Doc. I will now turn it over to you for your presentation.
Well, thank you for the introduction. Like I was introduced, my name is Dr. Jamila. and I'm an obstetrician gynecologist that was board certified as of 2014. I'm very excited to talk to you guys about different aspects and areas of women's health with some highlights. I was going to focus on just what to expect for a gynecological exam, the timing, when you should go, who should go. Also, I was going to kind of talk about healthy conception, advocacy during labor and delivery, and then what are the differences between perimenopause and menopause itself. So I'm just going to kind of get into the presentation right now. So the question is, when should you start seeking care? And pretty much the answer is at any age after onset of puberty. This may not apply to everyone on this call, but obviously we have friends and families that's female. So some of this information you can kind of carry on to the friends and family. So if they need the knowledge, you can also provide it to them. So once again, at any age after onset of puberty is when women should be seeking care, or young ladies should be seeking care. So I broke them into categories because in each of these categories, the care that you need may be a little bit more specific or detailed. So I'll go through all of those things as we go along through the presentation. Okay, so why do you need to seek care in the first place, right? There could be a variety of reasons, but here are some. So before the age of 21, normally I tell my mothers who have like teenage daughters or young ladies that's going off to college, these are pretty much the reasons why they should come see me in the office. And mainly is to kind of like get an idea of like how their periods are, talk about any kind of like sexual related questions they may have. And then mainly is just to get them involved in their own care at an early age so they know what to expect moving forward as they get older in their lives. So like if girls are having issues with their periods, they should definitely come see me. I know there is some overlap between myself and a pediatrician at this age, but a lot of times the pediatricians like to turf them off to me, especially when it starts to get involved with their periods. And so if they are having like very painful periods, infrequent periods, that is definitely a good time for them to see a gynecologist in the area just to kind of try to troubleshoot or like try to even reassure, because a lot of these things are just normal, especially in the first 7 years of a girl's when she starts having a period. They tend to be irregular or painful, and so just providing reassurance that there's nothing particularly going wrong is really a good reason to come see a gynecologist. And also to, if there is something that's out of the ordinary, to try to get to actually fix it early on versus waiting many years to do so. And also like with my young ladies that's going off to college is actually a nice way to start talking about like sexual transmitted diseases, making sure that HPV vaccine is up to date, talking about safety and sex, and then providing them with any contraception that they want at that point. Moving right along, I kind of touched on some of these things, but like sexual transmitted infections, normally we start all females between the ages of 15 and 25 we are obligated to do gonorrhea and chlamydia screen on them. If they need additional screening for like HIV, syphilis, and hepatitis B, we can do those things at any time upon the patient's request. Just to note, herpes is not routinely tested unless there's a sore that someone is concerned about, but it's not really recommended to do blood work for herpes because of just how common it is in the general population. All right, so moving right along to age 21 to 29 bracket, once again, whenever you come and see a gynecologist, we like to get if information or history about your menstrual cycles, because a lot of times that lets us know if things are in the right direction or going in the wrong direction. We do pap smear screening, and a lot of times people confuse a pap smear with a pelvic exam. In layman's, it could be together, but it's actually two different things. So when we do a pelvic exam, everyone, the dreaded speculum comes into play where we do a speculum. But like in our younger girls that's less than 21, especially if they're virginal, we may not even do a pelvic, we might not do a speculum exam, which is the little device. But we may just look on the outside to make sure everything looks okay and an opening is appropriate, right? But for us to actually do a pap smear, which is cervical cancer screening to look for HPV and any abnormal cells of the cervix, unfortunately, we do need to do the speculum, insert the speculum in, because that's the only way we can actually visualize the cervix, right? And we start that screening at age 21 all the way up until age 65. If all is well, we do it every 3 to 5 years. Obviously, if we find any abnormalities, the guidelines are kind of tweaked in a way where we may have to follow you much closely, a lot of times every 12 months until whatever abnormality is there actually goes away. So going in once again in this age bracket, we look at STI screening because once again, we want like all girls between 15 and 25 are screened for gonorrhea, chlamydia. We talked about contraception management, and we use contraception like birth control pills most commonly for obviously prevention of pregnancy, but we also use contraception for other issues, right? So like let's say if a female has a really bad acne issues, sometimes we will actually start them on birth control pills to actually reduce their acne symptoms. Also, let's say if someone is and have bad periods, be it painful or irregular, we may start birth control pills in that situation as well. Sometimes if you're going on a trip, I have like a subset of women that may do these religious pilgrimage and they don't want a period while they're away on this vacation. We could do birth control pills for a short course just to prevent those things. So we use contraceptions in a variety of ways. But of course, in this setting, I'm talking about contraception. And then also at this age group, we start the discussion on preconception counseling. So, trying to get the ideas about if they want to have children, if they do, the timing of having children, and then kind of like optimizing what other issues they may have to have a healthy pregnancy. At this age, we do what we call breast awareness. So, in this case, it's just mainly we've moved away as a specialty from saying breast examination because we found that it was providing women with a lot of anxiety because people were feeling like, oh, I'm not doing it properly. What if this happens? So we moved away from the term of saying self-breast exam to breast awareness. And what that means is just feeling your breast, right? So you want to, and you don't have to do it like we like for you to do it routinely so you'll know how your breast tissue feels, but you can do it as often as you like. You can do it every day because when you're showering, you can always feel them. You can do it once a week, but you just want to get routinely in the habit of checking your breast. And if you don't want to do it, if you have a significant other, they can do it for you. But just so you know what your breast tissue feels like is why we promote breast awareness. And then lastly, we look at health maintenance outside of the gynecological world. So we may order like a thyroid test to make sure your thyroid is okay. We may look at your lipid panel. Obviously, your blood pressures and pulse is checked each time when you come for a visit. So if we notice there's any variations or anything that's out of the norm, we can actually address it during that visit. So I kind of touched on these things. So moving right along, these are some of the methods of contraception. We have the pill, the patch, and a ring. There's multiple options. We can even talk about the pills that's on over the counter now. That's for birth control pills. It's a little bit different from what is prescribed by a physician, but it does work for birth control. Once again, I just kind of talked about cervical cancer screening, how often you get it. And one thing I wanted to touch on in this slide is that, HPV is tested each time after the age of 30, right? Versus before the age of 30, we just added on if there's an abnormality in the pap smear. And then the HPV vaccine, a lot of times girls are getting the vaccines during adolescence. So we like to start it between the ages of like 10 or 11. And now boys are getting vaccinated too. And there's a reason for that. But the HPV vaccine actually prevents against the most common strains of HPV that can go on to cause cervical cancer or genital warts. Okay. And so obviously there's over 50 strains of HPV, but in the vaccines, they get the most common ones. So even if you've been vaccinated in the past, you still can come across HPV if you're not using condoms each time to have sex. But at least the most common ones you've actually been covered against. All right, so preconception counseling. I know that was a question that was sent over to me by the health department at CTA to kind of talk about. So, the steps towards healthy conception and pregnancy actually starts before you even get pregnant. Okay, so preconception counseling, even though this is nothing that is like promoted often, it should, because it actually can help catch things before they become a problem in pregnancy. Okay. And so when we do preconception, and you can actually, when you're going to see a gynecologist, you may say, oh, I have a primary care doctor that takes care of all my other health needs. And you do have some primary care doctors, especially like family practice doctors and internal medicine, that will do some women health issues. So they will do your pap smear. They will order your mammogram, but they may not necessarily talk to you about preconception counseling, because that's kind of more of an OB-GYN specific issue. And so if you wanted to see a gynecologist, you can just make an appointment for preconception counseling. And the whole point of of this counseling is to kind of review your history, your menstrual history, right? Because some women may have been trying to get pregnant for quite some time and haven't been successful. But when we talk to you about your menstrual cycle history, we find out, oh, okay, there are some issues there that is probably preventing you from getting pregnant. And typically we tell women that if you've been trying actively for 12 months, and actually, let me move back. Let me go back for one thing. So depending on how old you are will determine if there is actually an issue that is being identified. So if you're less than 35 and you've been trying for at least 12 months to get pregnant, you have not successfully been pregnant, then there may be some issues. Okay. And so that is actually a good time to see a gynecologist to kind of see, okay, what are the issues? And then obviously, if you're over the age of 35, that time frame to wait is actually shortened to 6 months. So if you've been actively trying to get pregnant for 6 months and nothing is happening, you definitely want to see a gynecologist just to kind of see what is going on. And all of those things can fall under preconception counseling. But also we can do an infertility workup. But I don't like for women to wait that long before they actually come to see us, because once again, some things we can kind of take care of before they become problems. So in this preconception counseling program segment, we talk about menstrual history. We talk about timeframes of when to conceive, like I just mentioned. We look at your history, like just your regular medical history, to see if there's any issues that will come up that will prevent you from getting pregnant, or will even, once you do become pregnant, may be a problem obstetrically. Some of those issues include PCOS, right? PCOS is a huge one that can cause infertility issues, okay? So if we know ahead of time that you have PCOS, we would do what we can so that the disease won't impact your ability to get pregnant, or we just know, okay, what we'll need to, that we may have to allow a little bit more time for you to become pregnant. Obstetrically, let's say if you have a history of high blood pressure outside of pregnancy, right? We want to optimize that. So put you on medications that will help control your blood pressure. But most importantly, if you're already on blood pressures for high blood pressure, we want to make sure you're on the appropriate ones that won't cause you to have problems once you get pregnant, because some blood pressure medications, and for instance, there's a class of pills called ACE inhibitors, and they tend to start with pril, so lisinopril, enalapril. Those medications are contraindicated, meaning you cannot be on those pills if you're trying to get pregnant, because if you are on those pills when you're trying to get pregnant, they can cause the baby to have some anomalies, right, which are like abnormal features, which we do not want. So if you are on these medications and you come for this preconception counseling visit, we can take you off of those and put you on something that is safe to have during a pregnancy. Um, so also we look at some previous surgeries that you may have from a gynecological standpoint. If you had like a previous surgery to remove fibroids, depending on how many fibroids and most importantly where those fibroids were located, would determine if you can even have a vaginal delivery or we have to automatically do a C-section. Okay. Also, we look at what medications you're on, like I mentioned before, like with the class of blood pressure medicines. We look at smoking. If we can stop the smoking before you get pregnant, that would be great because we know that people and women that smoke, they tend to have babies that are smaller. That's one issue. And then the other issue, they have issues with their placenta. And then obviously, if you're on recreational drugs, I know marijuana is a really big one. And of course, we haven't had studies where we just look solely on women that smoke marijuana. Um, Overall, yes, it can have some of the similar effects to smoking tobacco, but the medications that recreational drugs that we're most concerned with, obviously, is cocaine and amphetamines, because those things can actually impact like the pregnancy itself in more significant ways. And then also like previous pregnancies, just knowing like, okay, when was your last pregnancy? How did that last pregnancy go? Did you have any conditions like gestational diabetes? We know that women that had gestational diabetes in one pregnancy do have a higher rate of getting it in the pregnancy, and they also have a higher rate of just having type 2 diabetes over a lifetime. The quote is about 50 to 70% of women that have gestational diabetes in pregnancy, right, will have a lifetime chance of getting diabetes outside of pregnancy. Okay. And then also we kind of discuss like lifestyle changes, especially if if we feel that you may have some issues with getting pregnant or having a successful pregnancy. The biggest thing I'm seeing right now in the office is obesity. Obesity is huge, right? And then if you look at the statistics just overall as a nation and as a world, like just around the world, the obesity rates here in the United States, all people, all races, is at 44%. I'm not talking about overweight. I'm just talking about obesity alone. So whoever has a BMI over 30, about 44%. And then if you start to categorize it based on race, certain races have even more higher rates than others. So like in particular for African Americans, that rate is close to 57%. Right. And so we know with obesity itself, it causes so many issues. And I'll talk about that in the next slide. So if we find that, okay, the weight may be an issue, we'll try to work on those things before you try to get pregnant so that you won't have the complications during a pregnancy. Also, we talk about prenatal vitamins. It's always good to start these prenatal vitamins at least 3 months before you get pregnant, because one, it ensures that you have adequate amount of iron levels, have adequate amount of folic acid. And folic acid is actually very important in the neural tube development of the baby. So it prevents those things called spinal bifida, or like that hole that's in the back of the baby's back. So if you have sufficient amount of folic acid, you can actually prevent those things from happening. So as a result, we make sure that if you take them at least 3 months before you get pregnant, those levels are adequate enough to kind of prevent those things such as anemia and folic acid. And then I also found that if you start prenatal vitamins at least 3 months before you get pregnant, it actually reduces the significance or the intensity of nausea, vomiting, and pregnancy. So I decided to make the obesity and pregnancy a whole separate slide because we know that it affects all of these things listed here. So we know that women that are obese, they like the overall miscarriage rate among women is like 25%. But in women that's obese, that rate can go up as high as 40%. Okay. And so we know that obesity causes infertility issues and subfertility, especially with people that have polycystic ovary syndromes. Like I mentioned before, it increases your risk of miscarriage. It also increases your risk for congenital defects, such things such as neural tube defects. And one of the things that they find is that with obesity, with the excessive amount of fat, it produces certain like molecules that actually changes like the actual quality of the eggs in the embryo, which then predisposes you to the congenital defects. And also they found that if you are obese, right, and you're pregnant, those same kind of molecules can cross over to the fetus that's unborn, change their genetics, and then predisposes future pregnancies or future children to obesity as well. So it has a lot of implications and issues over time. Also, women that's obese have a higher rate of developing preeclampsia or gestational hypertension. This is solely just in pregnancy. It has nothing to do with outside of pregnancy. So you could have not have any kind of hypertensive issues prior to pregnancy, but then in the pregnancy itself, you develop these things. Same thing with diabetes. Like, you probably didn't have diabetes before the pregnancy, but during the pregnancy, just because of how things changes physiologically, now you're predisposed or have an increased risk of having gestational diabetes. Also, it causes increased risk of having big babies. You're like, oh, what's wrong with having a big baby? They're really nice and juicy, and cuddly. But the problem is, during delivery, it may not be as exciting, because one, the babies most importantly, these babies can get stuck being delivered vaginally, and then they can go on to have something what we call a shoulder dystocia, which can, after being delivered, the baby can have like a paralysis in their hand. Oftentimes it's transient, it goes away, but then there are those cases that becomes permanent, and then they just have this permanent paralysis in the hand. So it's not good in that sense. And also, from a vaginal standpoint, when you have a really big baby, you increase your risk of actually tearing significantly, to the point where you can even have a 4th degree. So we don't want that. Having obesity, you at increased risk of having a premature baby. Sometimes it could just be spontaneous, where there's nothing going on and you have a preterm delivery. But a lot of times it's because you may have gestational diabetes or high blood pressure, and then because they're starting to impact the baby, a lot of times the obstetrician will be like, okay, we're going to have to deliver this baby early so that it can make the baby is delivered safely, and so you're safe as well. Once again, you want to start the prenatal care as soon as you find out you're pregnant. Okay, when you call the offices, so you want to start because, okay, obviously we want to make sure that everything is fine, but because of the climate right now, there's like a decreased amount of doctors overall. We're having problems recruiting doctors. We have a problem recruiting people to come into medicine. So a lot of times, if you have not established care before you're pregnant and you're trying to establish care now, you're a new patient. And some offices are having like a 3, 4, 5, 6 month wait just to come in and see a doctor. So just be mindful of that, so that if you're knowing that, okay, there's not a lot of doctors in my area, right? I need to start calling soon so that I can get established care. But we like to start care at about 10 weeks, right? But if you find a doctor and you can get a spot before them, then, at least you're already plugged into the system, and then we can get your ultrasound and things like that. But with prenatal care, there's 10 official visits. In the beginning, you're not seen as often. You're only seen every 4 weeks. Starting about 28 weeks, where when you're in the 3rd trimester, we start to see you every 2 weeks. And then obviously, once you get to like the 9th month of pregnancy, we see you every week, because normally towards the end is when, if you're having any issues, we identify them, and that's when most things happen, is towards the end of the pregnancy. During these visits, we know obviously we look at your blood pressure, we look at your pulse, we look at your weight, we look at your urine mainly to make sure that you're not spilling glucose or protein, because those things can kind of be an indicator that you're going to develop high blood pressure or diabetes. So if we start in the beginning, we have a baseline, so that as you move on in a pregnancy, we'll know like, hey, she didn't have that before. What's going on? If you have not had a pap smear, we actually catch you up and we'll do your pap smear at the first visit. We do STD screening, and this is like a state. It varies state by state. Here in Illinois, we are obligated to do STD screening at the first visit and also in the third visit, third trimester, so around 28 weeks. So when we do the STD screening, we screen everyone for gonorrhea, chlamydia, HIV, syphilis, hepatitis B, and hepatitis C sometimes. Also, we do OB ultrasounds. In the beginning, we do it just to make sure that your due date or the pregnancy is at the time that it's supposed to be based on your last menstrual period. Because for some women, if let's say they have a history of irregular periods, they're not quite sure when they got pregnant. And so, the ultrasound in the beginning is mainly to confirm when, if your due date is actually will be determined by that ultrasound, or if it's okay to be determined by your last menstrual period. On an ultrasound, not only do we look at the determination of how, when the baby should be due or the size, we also look at maternal structures. So sometimes that's when we'll find out like, oh, you have fibroids and you have a big one, or you have a really big cyst in your ovary, and we may need to do something about it at some point in time. A lot of times, we try to wait until after pregnancy to do these things. But if we find it and we know it's going to impact the pregnancy, we know that, okay, if we have to intervene on some of these things, we can do it actually like once you are past the first trimester, and then we'll do it at that point. Sometimes with fibroids, I've had situations where I had fibroids that's probably as big as a dinner plate or a salad plate, and it's in the wrong area. It's like blocking the entry. So in those women, they may have a normal sized baby, but they have to have a C-section because this fibroid is blocking away. And because we knew about it before, we can plan the delivery much safely. We do genetic testing we look at mainly the three main the main common genetic disorders, being Down syndrome, trisomy 18, 13. But in that genetic testing, there's a new one that we even can find out the sex of the baby. The sex of the baby is medically, there really is no reason why we need to know it, but I know women get very excited that we can do this blood test to see it, and so we do it. But the reason why we need it is not for this reason to know it's a boy or girl, but just to make sure, like, if there is certain complications, like certain things tend to run a little bit more in male gender babies versus female gender babies. We also look for diabetes. If you have risk factors prior to being pregnant, we may do that glucose test early in the first trimester. But we typically do it in the third trimester, because we know just because of what's happening physiologically while you're pregnant, it does increase your risk of diabetes. And so we want to kind of like catch it at the timing. And then we do a swab at the end at 35 weeks to make sure you don't have this bacteria, because if you deliver vaginally and you have this bacteria and we don't know it, oftentimes what can happen is the baby can get really sick. So we screen for it, treat you for it, and then the baby can come through successfully. And obviously, if you need any referrals to like a high-risk doctor, especially if you're over the age of 35 or have any pre-existing issues, like let's say if you're a type 1 diabetic or you have bariatric surgery, a lot of times we have our high-risk doctors follow on in addition to us generalists, just to make sure there's all eyes, all hands on decks, and there's multiple people seeing you, making sure that your pregnancy is successful moving forward. one thing I know that you guys wanted me to talk about is pregnancy and self-advocacy, especially with the rates of maternal mortality and it being higher in certain demographics, in particular African Americans. I know some of the barriers to pregnancy and self-advocacy is one is lack of trust on both patients and provide both doctors or midwives or nurse practitioners. Obviously, access to care is a huge one, and also knowledge gaps. So, a lot of times, if we can work on those issues before you get pregnant or early in a pregnancy, that these things kind of ensure that moving forward, that you'll have a successful pregnancy, a successful delivery, and a pretty good postpartum period. Because the thing is this, the reason for those 10 visits, besides you being able to make identify medical issues that can come up during a pregnancy and making sure you is safe and the baby is safe and you have a successful delivery, one of the big things that achieve is like it actually increases the trust level between the patient and the provider. I know in some clinics, they have multiple doctors, and depending on how they decide to run a clinic and a mode of the clinic, they may want you to meet all of the providers before you deliver. And depending on how big or small that practice is, you may only see one person one time. But once again, at least you got an idea of who these people are, right? So that when you're delivering, at least you've had some kind of relationship and you know what the expectations are. So I think that in itself, and going into those into that setting and knowing like, hey, I need to trust the process. These I mean, yeah, of course there's personality issues, but at least you can identify them early and then you will know how to work around it. And so with the doctor. And then access to care, like I mentioned earlier in a presentation, just because there's just a decrease in amount of doctors that can provide care, especially in this area, you want to try to establish care early on, right? So that you can identify some of these issues before they become bigger. And then knowledge gaps, just educating yourself. Yeah, Google, TikTok are they're we have them, use them, right? But obviously, you want to educate yourself in other ways, by asking questions at your doctor's visit, going to some of these prenatal classes, because those, once again, they're giving you information that's more evidence based and sound versus anecdotal stuff, right? And then also you can bring your family members with you to the visits, because it's I love it when I have the significant other, like the husband, father, the baby in the visit, and because I tell my patients, normally they the biggest snitches. So they'll tell me if if my mom is not doing what she's supposed to do, or she's downplaying whatever issue she's having. He'll say, no, she's actually throwing up much frequently. So then I'm able to know, oh, then let's try to fix this. And it's not just, and we don't, not just the parent, the father or the significant other have to come. It could be mother, mother-in-laws, sisters, cousins, whoever that you want to bring to the visit. We would like for them to be engaged as well, because, well, once again, those people being involved will actually ensure that your pregnancy moving forward would actually be okay. Now, I know I kind of segue out of what, the different timing of gynecological visits, but I'm going to move back into that. So between the ages of 30 and 39, unlike just like the 21 to 29-year-old age group, we still do some of the same things, like looking for menstrual cycle changes, pap smear screening. But at this time, we're trying to get you prepared and ready that you're going to need your mammogram starting at age 40. So at age 40, that's when we start mammogram screening. So we screen everyone for mammogram starting at age 40 up until age 75. And it is every single year. Okay. I know that there's two sets of guidelines out there, and some people say, oh, between the ages of 40 and 50, you only need it every 2 years. I mean, that's fine because that guideline actually comes from the United States Preventative Task Force. But most providers and most doctors out there would do it every single year. At least even if you skip it, at least you have the order, and we'll make sure you have it the next year, because then it's very important that you get these screenings done, because unfortunately we're starting to see women develop breast cancer at earlier ages. Also, at between ages of 40 and 49, we start to talk about what changes you should be expecting in terms of your periods, because at this point, now you're entering into the perimenopausal period, and we're going to talk about that a little bit later on. Colon cancer screening. So depending on if you have risk factors that say a family history of colon cancer, or if you come from certain ethnic groups like Black Americans, we actually want you to start getting this colon cancer screenings at age 45. So at this visit, I can put in an order for you to get to see a GI specialist to get that colonoscopy screening performed. So like I mentioned here, just kind of touch about breast cancer screening. And then at these visits, we ask you more detail to find out like, hey, do you have a family history of breast cancer? And then if you do, we try to get you connected with a genetic counselor to see if that breast cancer is actually genetically linked. Because if it is, there are special things we need to do for you to prevent you from developing some of the things that's affiliated with these genetically linked breast cancer conditions. So in particular, BRCA1 and BRCA2, if you have that gene, we will offer you to have a prophylactic mastectomy, meaning we'll remove both of the breasts. Now, you don't have to remove it early, but we'll wait until you're done with having your children, and then we can make the referral to a breast surgeon and say, hey, this particular person has a family history of breast cancer, and she actually has the gene. What are your thoughts and recommendation? And it's a joint discussion. So it's not something that you have to have done, but it is something that can be offered to you. And then also the same with those women that have that gene, BRCA1 and 2, are actually at increased risk of having ovarian cancer. So as a result, once you're done having children, we may offer you a prophylactic oophorectomy, meaning we'll offer you the opportunity to have your ovaries to be removed, so it reduces your risk of ovarian cancer. So that, in that, when we see you for these visits, we can get some of this information from you, and then we can kind of work on it throughout, time. So this is just a slide about abnormal uterine bleeding or menstrual cycles, right? And so, on this slide, it just kind of tells you like what is normal and what's not normal. Okay, so pretty much periods, the 28 days is kind of like the midpoint that we look at, but normally normal periods can be anywhere between every 22 to 35 days, right? And you have your cycle. It's like a calendar. It's never going to be 28 days. The calendar is not perfect. It's not every 30 days. It's 31 days. It's 28 days, 29 days. So your periods are the same. So it's a range, and it's a short range too. So it may be 28 days plus minus 2. So it may come every 27 to 29 days. It may become every 22 to 25 days. But if you know what your periods are, if things are starting to go haywire, you'll know and identify it much earlier. So, once again, when we ask about the menstrual cycles, we're doing it just to kind of pick up on any issues that may be different. Also, in terms of the length of bleeding, you should bleed anywhere between day 3 to day 7. Anything longer than day 7, we know is absolutely abnormal, and we need to figure out why. If you're bleeding less than 3 days, same thing. Why? Is it something that I'm doing? Like if you're on birth control, women that tend to be on birth control, and let's say before birth control, they have a menstrual cycle that's every 3 to 4 days. We do know that once you're on birth control pills, it may shorten and lighten your periods even further, that you only bleed 2 to 3 days. But if you're doing this on your own, we kind of have to figure out why she's doing this on her own. Okay, and then once you get to the age 50 to 64, we continue to do pap smear screenings, because like I mentioned, you do them every 3 to 5 years until you turn 65. So we still are doing them in this age group. We're still doing the mammogram screenings, obviously. All comers will need a colon cancer screen starting at age 50. If there's no polyps, normally it's every 10 years until you turn 85. Obviously, if there are polyps, then you may have to go a little bit more frequently. And definitely if you have a family history of colon cancer. And in this age, that's when we're starting to find that your ovaries should be winding down and that you are at menopause. So we can actually talk about some of the signs of menopause. And so, because a lot of times these things start happening, and women like they start getting freaked out, like what's happening? They don't know because like maybe their moms didn't talk about it or they had a hysterectomy. And so they didn't really necessarily go through these things. So now here they go feeling these hot flashes and they feel like they're dying and then or they can't think or they can't sleep and they're just like, what is going on with me? A lot of the reasons because of menopause. So when you come to these visits, we can kind of start prepping you to know, okay, this is what you're going to start expecting, and you should have started expecting at this age, just to kind of reassure women. And then if they need treatment, we can offer it to them, or just so they can just be more comfortable saying, oh, this is what it is, but it will end at some point. So bringing me to menopause. Okay. So what is the difference between perimenopause and menopause? So the main difference is actually what is happening with your period. That's first and foremost. So perimenopause is like you're starting to make the transition, but you have not stopped your periods yet, right? And that transition can happen about anywhere between 5 to 8 years before you actually stop having periods, right? So depending on when you go into menopause, that those things can actually start happening as early as the late 30s going into your 40s, right? And so, this, and I'll talk about what the signs are after this slide. But yeah, that's when you'll start to see these changes between ages 30s and 40s. Okay. And then some women, they start to have irregular periods, right? So before they probably had a normal 27-day to 29-day period, came like clockwork. Then all of a sudden, their periods start skipping. They may not see it 1 month, they may not see it for 2 months, but they do get a period at some point, right? But if they go 12 months without a period, you're officially menopausal. So then that's what actually makes that differentiator, is whether or not when your period stops. So in perimenopause, let's say if you don't have a period for 11 months, you're still perimenopause until you go 12 full months, and then we can say you're menopausal. But if you're perimenopausal, you have no periods for 11 months, and you get one at 11 months and 5 days, guess what? You have to go back. Okay. We start the clock all over again, and then you have to wait another 12 months for that period not to come back again. So that's the biggest thing. In this country, average age of menopause is 51 and a half. Okay. And so, but it can happen anywhere between age 40 to 57. And then these are the signs and symptoms of menopause: hot flashes, night sweats, problems sleeping, mood irritability, vaginal dryness, pain with intercourse, and then urinary issues. Some of the things that I did not include on this list, because that's kind of like plus or minus, is memory issues. But normally that comes as a result of you not sleeping well. Okay. Sometimes people have a lot of like joint pain, muscular issues. And because once again, you have estrogen receptors on your muscles and on your bones. So you as those hormone levels start to fluctuate, you'll start to notice changes in all of these different organ systems. But the main ones are on this screen, and the severity differs, right? So for some people, they may not even have any symptoms at all. Only way they know they're in menopause is that their period stop, and those women are very fortunate. But and then you have those women that, oh my God, they feel like they've been on fire ever since they were 32, right? And so, but for the most part, most of us fall in the middle range where they come and go. They're bothersome, but they're tolerable, right? But if they're not and they're interfering with your life, please know there's help. And we have a whole variety of things that we can offer. Obviously, estrogen is the gold standard, but we have other non-estrogen based hormones or non-estrogen based medications that can help with these issues. All you have to do is just tell us, and we can review what these things are. I talked about colon cancer screening. I talked about briefly before what we look at. We can order blood count. Let's make sure you're not anemic. Look at your thyroid, and look at your hemoglobin A1C. And then lastly, in an age 65 and older, obviously we stop pap smear screenings at that age unless there's like an abnormality 10 years before. Then we may continue screening for an additional 10 years. But for the most part, we stopped doing pap smears. We still do pelvic exams because we want to make sure that the tissue looks good. There's nothing falling, because you can have prolapse as you get older, where your bladder may fall, your rectum may fall, or your uterus may fall. But we can pick up these things if we do the pelvic exam. Also, we can pick up urinary issues you may have. We start to screen for like bone thinness or osteoporosis, and then we continue to colon cancer screens. So osteoporosis, once again, it's a bone scan. It's an X-ray kind of device that you go through just to see how strong your bones are. If your bones are good, you do it every 5 years. But if we find that your bones are getting weak, we do it every 2 years. But we try to do some kind of intervention to try to slow down that bone loss. And that's pretty much it. So, that's my presentation, and I'm very open to any questions you may have.
Thank you so much, Dr. Oko. That was a wonderful presentation. I do have a question in the chat here for you. It asks if you can talk a little bit about pregnancy after 35 and what actually makes it high risk.
Okay, so what makes it high risk after 35 is a few things. One, most importantly, is egg quality. So as you get older, all the eggs you're going to have babies you were born with as an embryo, right? As a baby. So as you age, those eggs age with you. And we know after you hit 35, the likelihood of having embryos or eggs, I should say eggs, that are abnormal goes up a little bit. Okay, it goes up higher than what it is when you're less than 30 or 35, right? And when you get to 40, it even gets that risk even goes up even higher, right? And so the main issue is egg quality. Okay. But then, just because we know that can be an issue doesn't mean that should prevent you from not wanting to have kids. You can have kids. Some women get pregnant late. Some women decide late that they want to have kids. We'll support you wherever you are. And that's why we do the genetic screening test, so we can pick up on some of these abnormalities, if they happen when you do get pregnant. So that's one. And then the other thing is, by the time you hit 35, you're starting to, like, certain health conditions starting to become more of an issue, right? High blood pressure. Some women are diagnosed with high blood pressure as they get older, as they get to 35 and 40. You tend to be heavier, right? Also, you may have cholesterol issues. So now you're having medical conditions on top of being pregnant. And we know just because you're pregnant, it will make those conditions even worse. So that's why having a baby after 35 becomes a little, it's considered high risk, and you just need more attention. That's it. I won't ever tell anyone not to have a kid, but we just know we like to be prepared, and you be prepared, and make sure we ensure that you have a healthy pregnancy.
Absolutely. Thank you so much. We have another question here. It asks, what are the kinds of non-estrogen based supplements or medications that are available? Also, is estrogen a contributor to breast cancer?
So, I'll start with the first part of the question. So, supplements, I know there's a lot of supplements on the market, right? The ones that you will have a gynecologist say that are okay or appropriate is black cohosh, Daquan, which is like an Asian supplement, and there's another one that escapes my head. The problem with supplements is that we know they work, but we don't know the potency, because they don't have any studies to say, hey, you need XY amount for these splashes to go away. And so, because we know that we don't have that data available, we don't know how much you need to actually get rid of your symptoms. And then sometimes, if you take too much of these things to get your symptoms to go away, they can become toxic, and then cause even other issues. So with the supplements, I mean, the ones that I mentioned, black cohosh and Daquan, those are fine, right? But anything outside of those, like, I know there's Estroven, which is a soy-based one, and those are capsulated, and they can work too. But a lot of times you find that those actually work in in cases where there are mild symptoms, right? So you're just having occasional hot flashes. If you're having more severe symptoms, those things may not work because once again, we don't know what the potency or the specific level you need to actually make to level out the symptoms that you're having. Now, on a like prescription based, we have, depending on what your issues are, we can do Clonidine, which is actually a blood pressure medication, right? But we find that if we give it to you, it can actually, it helps, it does very well in helping with hot flashes, especially during the day. There's gabapentin, which is a nerve agent. We find that if we give it to you at night, that would actually not only help with the night sweats that you may have, but it makes you sleepy and it puts you to sleep. So that's another option. Other things, sometimes we work with antidepressants, in particular one called venlafaxine. Okay, that because your venlafaxine, it prevents serotonin and norepinephrine, which are two like neurotransmitters on your blood vessels. It kind of helps stabilize your the hot flashes, and you do fine. So that's another option you have. But yes, in terms of the other question about hormones can increase your risk of breast cancer, yes, it can, but so can other things, right? But as long as it's done in a safe way and we know that your mammograms are fine, we can give these things safely and you have no issues. Okay, so I don't want people to stray away from like hormones because of the increased risk of breast cancer. It also can increase your risk of like cardiovascular disease, such as high blood pressure and heart attacks as well. But like I say, depending on how much you get and what route you get it, because sometimes some people have vaginal issues, such as painful periods and or like burning, vaginal burning. And in those cases, if they don't have hot flashes, we can do vaginal estrogen. And in the case of vaginal estrogen, the amount that goes into the circulation is so minuscule that it does not increase your risk of breast cancer. So it just depends on the symptoms. And then, we go from there.
Wonderful. Thank you. All right. We have another question here asking if you could please expound on the pelvis falling after 65.
The pelvis problem. So with the pelvic problems, now not all women are predisposed to it, right? But there are some women that, they may find that their bladder drops or the rectum drops or things like that. And what the symptoms that the way we know it is that people say, oh, when I'm washing up, I feel this small bulge in their vagina. And then when they come in and we do an exam, yeah, you notice that things are sagging a little bit. You are sagging. Sometimes it could be a little bit, sometimes it could be completely, right? A lot of times too, like they'll have urinary issues, right? And so sometimes you'll find that, okay, they're going to the bathroom, or more so they can't empty their bladder all the way. Okay, now, yes, it could, a lot of times it could be related to the pelvic floor being more relaxed, but sometimes a lot of times actually we see it because there's just there's no estrogen, and so it cannot support these tissues. So a lot of times, sometimes just giving vaginal estrogen, you'll find that the tissues get better, and then with pelvic floor therapy we can kind of help with these things. But that's normally in cases where there's mild prolapse or mild relaxation. And things that's more significant, then you'll probably need to have more aggressive or active management, meaning in a sense of you may need surgery to help bring things up, or there's a pessary that we can do, for people that don't want surgery at that particular point to kind of keep things in place.
Okay, perfect. Thank you so much. Hopefully that answered that question there for you. We have one more question before we close out. What options do I have to decrease inflammation with RA and endometriosis?
Inflammation with RA and endometriosis. So the thing is, you got to understand what these disease processes are, right? So in RA, right, that disease process is like your own immune system is attacking your joints, right? So it's not an inflammatory, it's not quite an inflammatory response, it's an immune response, right? Which is a little bit different. And so the main thing, depending on how severe those symptoms are, You probably need to be on some kind of medication to lower the amount of antibodies or these immunoglobulins that's actually attacking your joints. Okay. Now we do know if you are obese, the fat cells itself produces inflammatory markers, and so it can make that situation worse. Same thing in endometriosis. So if you have an inflammatory or some kind of autoimmune and you worry about inflammation, you may want to kind of control your weight, because we do know for a fact it's been determined that fat cells do produce inflammation. Now, in terms of endometriosis, that condition is not autoimmune. We don't really know why certain people are predisposed to endometriosis, but what happens is the lining, the cells that actually you bleed every month, actually goes to places where they're not supposed to. So as a result, as you're bleeding through your uterus, the places where these implants have went are actually responding to hormones as well, or your menstrual cycle, and then they bleed too. And then as a result, it causes pain because those cells are not supposed to be there. Right. So because they're not supposed to be there, that's why you get a lot of the pain symptoms that you have. Now, does losing weight or inflammation has anything to do with that? No, not really, because that's not how that's not the cause of the disease. The main treatment for those things actually is like to kind of control how much hormones you produce, so those cells that's outside of the uterus don't cycle as well. So it's a different process altogether.
Wonderful.
I saw a question up.
Oh, I think that was the last one.
Okay, I saw something about Mounjaro. I don't know if.
I did not see that. Was that directly
then it's fine.
to you? Okay. Okay, well, we can always reach out to Dr. Hoko with additional questions if anyone has them. You can also email us at wellness@transitchicago.com and we can help out. We want to thank Dr. Hoko for joining us today. It was a wonderful presentation. We really appreciate your time and answering all of those extra questions for us. I would also like to announce our raffle winners before we get off the call here. So congratulations to Jennifer Wilkins, Lily Bucio, and Callista. We will send you guys over an email shortly to let you know the details on that. I also have a quick friendly reminder to let you know that this is a self-reported activity for Motivate Me. You can report today's date on the MyCigna app or mycigna.com. And then also be sure that you are joining us for our Let's Get Moving campaign, which starts on June 3rd. All of this wonderful information that you got today can also be helpful as we get our bodies moving more starting in June. That concludes our presentation. I want to thank you all so much for joining us and have a happy and healthy holiday weekend. Take care.
Thank you for having me.
Of course.
Thanks, Des.